One of the things that I'm looking at, again, if we're thinking algorithmically going through our process again, is first and foremost looking at her brow position. Marissa's got a very well, thank you very much. She has a well-positioned brow. Have you look straight ahead right there. She's got a nice arch. She's got appropriate positioning of her brow. She doesn't have much of asymmetry between the two. Her left brow sits probably about 1 millimeter or so higher than the right brow. When we're looking at kind of going straight across here, you can see that maybe she has about 1 millimeter or so discrepancy. But importantly for her, and her brow sits above the level of the supraorbital rim. So when I'm looking at her, and if she were to come in talking about the aging periorbita for me, she has some upper eyelid dermatochalasis, right? So rather than thinking about, oh, well, her brow needs to be pulled higher, it's actually not correct. Her brow position's great, but she does have some upper eyelid skin laxity. This is a surgical issue, right? We do an upper blepharoplasty. She may need a little bit of medial fat removed from that medial fat pad around her eye. But here, for the most part, it's about some extra skin. So don't have this tendency to be like, oh, I'll just try to get her more of a peak of her brow, or let me put some filler in to try to create a little bit of a strut underneath here because I want that brow higher. It's far from what you need to do. She actually, heaven forbid anyone has surgery anymore, but she may actually need to come and see me for my scalpel instead.
She does have beautiful skin.
So, now, for her, remember I was joking about that concept of forehead. She's like a two-head, right? She's got a hairline enviable by everyone in terms of that capacity, but she doesn't have a lot of distance between her eyebrow and her hairline. So what that means if you're going to be doing neuromodulator injections for her is we really need to stay high on her brow, right? Because there is not as much distance here, so we really want to be careful that we don't get too close to her brow, because on her, if you do your typical pattern and you do multiple rows, the last thing you want to do is if you really even bring her down a little bit, you're going to really accentuate. You don't have to drop her brow to accentuate her dermatochalasis. You have to work very hard to do the opposite and keep her, nicely contoured, give her nice relaxation of that frontalis, but you can't try to inch in, 30 units or 25 units up here. That is far from what you're going to want to do for her. Otherwise, you're going to make things a little bit worse.
Now, remember, our neuromodulators usually diffuse 1.5 to 2 centimeters, right? Mm-hmm. Well, that's not very far here.
Right.
So I agree. And this is a patient who I would discourage from using much neuromodulator at all in her forehead, because she's got a short frontalis anyway. She's got this dermatochalasis. We want as much eyebrow lifting and positioning as we can just to combat that dermatochalasis a little bit. So, she doesn't. Do you have it in your forehead? No. So, no Botox in your forehead. Do you ever put Botox in your forehead?
I have, but I only do maybe 3 or 4 units.
Okay. So, that's exactly it. She only does maybe 3 or 4 units because she doesn't like the effect on her brows. So I think that two-brow person forehead person is really important to either stay away or do minimal dosing.
Correct. And then we would look at her glabella, we'll look at her periorbita, we've talked about that. Now, one of the things that we're going to do for her in particular are temple injections, because she has nice bimalar width, she has fullness in this area, she hasn't had any filler injected in a couple of years. Is that correct? So it's been a long time for her since she had any type of HA injected. So she's well tanked appropriately right in through here. We do not want to overfill her because it is going to make her face look too full. But one of the things that we are seeing, even though she doesn't have a lot of visible skin, I'm just going to rotate you this way, thanks Marissa, is we can see is that we do notice over her zygoma and that contour, we do have a little bit of this depression in through, and when we look at her straight on, that it's just kind of skeletonized in that area. So again, the goal with a woman's face is going to be to just add enough to create a little bit of that smoothness in that contour, but we definitely don't want a convexity, and we'll actually tolerate a tiny amount of concavity in that capacity as well. When she smiles, because she has beautiful eyes and a lovely smile, how about that as 2?
Yes.
Dr. S2.
Wait, Dr. S, I think you're learning.
Exactly.
I think you're getting the gist.
That's right. I'm going to be sitting in the front row taking notes in a second as well. So the fact of the matter is while working and she smiles and has this lovely smile, when she smiles, one of the things you want to definitely avoid in her, not that she has a tear trough, you have to be very careful about any periorbital injections because she, again, has fullness and is going to make her eye and her aperture very small. And it'll make it look like when she smiles, it's going to basically make it look like her eyes are closed. So again, she doesn't need anything really much in her nasolabial fold. She has nice nasal contour down through here, a little bit of a supratip break, and so we have nothing really to do much in through here. When we start getting into her perioral region, one of the things that we notice is some lip asymmetry. When we look at her, now you had your lips injected?
I have.
Some.
It's been over a year.
Okay, so it's been over a year, so she's close to, or at this point, pretty natural in terms of at a resting state. When she had it injected, when I'm looking at her, and I'm wondering if we can capture this in this image, even though there seems like there's some persistence, it looks like her white roll was pretty aggressively injected because I'm noticing a bit of a step off and not a natural transition in, through, and around her mouth. I'm just going to continue to rotate her in a few angles so we can kind of see how I just feel like it flips up.
So she needs something in her ergotride. I didn't actually notice that when we were in the room evaluating her, but you're exactly right. This is that old style, more duck feel that we need to do a little bit of product. This is not what I'm going to do it with. I'm just pointing. Just above that step off. I agree completely. What she pointed out, and she doesn't like, thank you, Jean-Ann, is she doesn't like this asymmetry. Look at the amount of red show on the right compared to on the left. So sometimes I'll take a little Q-tip and show patients with the mirror while they're holding the mirror. If I add just a little volume to that, what I want to do is give balance, because we do want these lips to be identical twins if possible. Here we go. But this, you can see that. And actually what happens, and what's happened here, she's had a little bit of swelling since she had the topical anesthetic on.
Sure.
And so I don't notice the asymmetry of the upper lips as much as what we're pointing out with this step off. So we need to treat this ergotrid just a bit and be very careful, because if you treat too much, you're going to obliterate the filtral column. So you have to eye and
Which
see.
she has a little bit of a flattened one anyway. So
Yeah, so we can augment it a little bit, And so we elected, when we discussed in the back, that we would use Vobella only because it is just very soft and we don't need a lot of volume and change, because overall her geometry of her lips is really quite nice. Now, we could use Restylane Silk. My only problem with Restylane Silk is I have had swelling issues. I mean, I just have to call a spade here.
And she said, I swell.
Yeah, so if somebody swells, then that's probably not our go-to product. I do use it for the barcode. I do use it periorally. Restylane Silk in Europe is used mainly as a skin booster. And so it's used kind of more globally in the face and superficially. And so that's another consideration for where we might utilize that product in our toolbox.
Perfect. So as we look and we've kind of discussed what our plan is for her perioral and for her temples, mid-face, again, we're very pleased with. Once we start working our way down here towards her lower third, and I'm going to just kind of start to rotate you a bit. Actually, could I just have you maybe sit just closer like that? Perfect. Because I think this will be helpful. And I'm just going to tilt you up. Good. We've got our Frankfurt horizontal plane in place. We can see in through here. So when we're looking at her jawline, she has this ever so slight, a little bit of this jowl bump. I'm going to take a pinch, and I assessed her earlier. You could actually look at my pinch test here. She really doesn't have that full of an inferior jowl fat pad, so I'm not keen on skeletonizing this and removing any more fat from that area. But what she does have, and I can see in a shadow here, and we'll see if we can capture that, she seems to have a bit of a masseter bulge, a little bit of fullness out through here. Bite down for me.
Yeah, it popped out.
Yeah, it did. Let's see if we can capture that.
But she's a little more mature, not old, slightly mature, that if you atrophy that masseter, I'm telling you, you're going to accentuate that. Agreed.
So that's why I wanted to look at the masseter bulge to see the difference in what was making her antegonial notch in this region a bit more pronounced. So in the absence of a palpable full jowl fat pad, a lovely but mature skin and soft tissue envelope, I'm coachable.
Yeah. Trainable.
Trainable. My mother would be proud. So, and then the fact is we've got a masseter bulge, and we don't want to exaggerate this because we're concerned about the skin soft tissue envelope. What we could do is very elegantly just fill that area, the cannula, and just work our way through, or single needle point, but we'll let you decide, and just place some filler along the jawline to just soften that, because she has a very statuesque neck. She has a very lovely jawline, and she's got a nice neck. It's just a little bit of through here. So again, I think along her jawline, anterior and posterior, we've got to pre-jaw sulcus a little bit, and then we can go back through there. And then we talked about narrow neck. So a little bit of early platysmal banding, which we can see that could be treated also with neuromodulator. So for purposes of our temple, Susan, tell me what because we have a couple of different
Okay,
approaches.
so what we're going to do is we are going to palpate her temporal fusion line and determine where her temporal crest is. Right here. You can feel that? Okay. So here's her temporal crest. It's not very long because we have such a teeny two-finger forehead. And so once you've palpated this temporal crest, you can come up a centimeter, down a centimeter, and go right into this area, exactly perpendicular, half-inch needle with Voluma, which is what I'm going to demonstrate for you. Okay, and we don't need any of the product to go into the hairline. So I'm actually going to, now this I'm going to have to get her in the right position, so I hope you can see it. And I can't see the monitor, so. Okay, so I'm going to let her know that she's going to feel I'm going to prime my needle. She's going to feel a little prick, and I'm just going to go now, tiny little ouch, right down to the bone, holding posteriorly. Very slow. Look at the plunger. Look at how slow and steady I am. And while I'm doing this, I tell patients, I'm not very good. I can't play the piano, and I really can't sing. But the good news for you is I have really steady hands. And patients are like, oh, okay, that sounded pretty good to me. I'm glad you have that steady hand. And see, I'm going just from one injection point, and I'm putting pressure with my left thumb, my non-dominant hand, and I'm just right down. I tap the bone gently. This is not forceful. Nothing I do has to be forceful. And then I slip around to the thumb, pushing the plunger, very, very slowly. And I don't inject more than 1 cc. I could have used Restylane Lift. I used to use Sculptra, but I tend to like the HAs here. And then I can just blend it and mold it in patients if they need it, all the way down to the zygoma. Now, really important, and Dr. Applebaum pointed this out at the break, now is when in your office, the magic mirror. Because if you don't show them the magic mirror now, and you do the other side, they totally forgot what they look like. And they don't appreciate it when they get to checkout and it's costing them, a ton of money. And patients do not come in asking you to inject their temple. We haven't seen it on television. It's rarely in a magazine. There's not a lot of talk about it. But when you point that out and you show the patient, it's particularly the runners, those skinny minis, those little, emaciated people with big hollowing, how much better they look if they have a little volume and they don't have this skeletal orbitalization around the orbital rim here. And it really didn't hurt, did it? No. So it really didn't hurt. I didn't put any local anesthesia in my injection point. I did a little talk anesthesia.
Very easy.
And that was very easy. So I think using this location, using that injection technique, quite honestly, I think it's even safer than the piriformis.
So perfect. Let's go and sit her up for just a moment so we can see and capture that. Thank you. And let's go ahead and turn her a bit towards me. So we're looking at that temporal fusion line, just like you mentioned so well, and then the point where you're kind of one up and one over in that capacity, which ends up being that nice injection site. I think we were just not capturing it. I was also going to be, later we'll talk about a different technique, because that way we can talk about
So
both,
if we did
which
the
is great.
superficial technique with
Exactly.
the cannula?
Yep, and I've got that on video, and that's why I just stepped away for a second. So
Okay.
perfect. So we can start with her injection and then go from there.
But you would not use the same product superficially that I use deep, correct?
Correct, 100%. That's why when I was talking earlier, excuse me, when we spoke earlier about product selection, we definitely want something that's on the
The
deeper
magic mirror.
side, a higher G prime, lifting capacity, sort of a thicker, more viscous product, something that's going to give us a bit more lift because of the fact that we're placing that deeper on that temporal fossa. So we're injecting basically through superficial and deep temporal fat pads, because we have 2 fat pads in this area. So for her in particular, no question, we want to use something like Lift, something like Voluma, something like a Sculptra. These are the types of products that you would want to be injecting deeper. Now, when we talk about the superficial cannula type technique, we 100% want to be using something that is not nearly that same thickness or that same type of G prime, because otherwise you're going to be left with something that's very difficult to mold and flatten out, and you'll end up seeing the product in that capacity. So I think definitely we want to contrast between the two.
Okay, now this is Bobella.
Okay.
This is look at that little bend. And this, did you ever do this little bending part?
I have not. But this is
I'm sending you home with some new thoughts.
perfect.
Okay, see that? Because look at this. It allows your hand to be in a much more comfortable plane than if I have to be down here when the needle's straight. So that little tiny bend. And then what I'm going to do is there's philosophies about whether you pull the tissue into the needle, being less painful than going at the tissue. So if I come like this and then I just pull it in, how is that?
Fine.
So see, it doesn't hurt so much. And slower injection.
And now here, in contrast to the first patient that you injected, with her you were right on to when we were talking about filler, you were working on the actual vermilion itself, wet-dry junction. Now you said you're kind of blending onto the ergotrid. So while you did that first pinch, when we control that little spot so she doesn't bruise, maybe we could sit her up so we capture the angle and you can show kind of where we were placing it, just so that we get a better view. Because right now, again, we have a little bit of that worm's eye view.
Okay, all right, let's sit up. So
Thank
see
you.
this? What I did was I pulled the tissue. I got a hold pressure here. Sorry, 1 second. Because I am using a needle and not a cannula, I have to be careful that if I do see that punctate bleeding, I have to hold pressure.
Absolutely.
And then I'm very gentle with this as well as the silk product with very low pressure molding. But I do tell patients when I treat this ergotrid, you're superficial and it does bruise very easily. We give patients ice. I don't know if that helps or not. It's my one little marketing. It has my logo on it. And it ends up in the kid's lunchbox. And the kid goes, oh, my mommy has that same one. So we do little ice packs to send patients home with. We give them some arnica. Again, I'm not sure if that helps or not, but I do. I feel like that I'm trying. There is another product called Dermend. Have you ever heard of that? Dermend?
I have not.
Dermend, it's a cream product that Steve Clark developed, and I think it does help a little bit with the bruising.
Well, we've been using a lot of our Occumend, the Occumend patches.
Yeah.
And I've been really impressed and fond of how well that's been working with decreasing a lot of post-injection swelling and bruising. So we often will send patients out with the Occumend patches, and they'll wear them for a day
They're
or two.
a little pricey for my Florida taste. That's my only problem on that one. But for New York,
Right.
I'm certain it's what's expected.
Well, I've budgeted in.
Oh, okay.
Yeah, it's budgeted into my practice.
Touche. So look at that. So what we've done is we've softened that step off.
Yep. And we can see it's much more clear here, but it is definitely transitioned. It went from, when we look, I'm going to just rotate you this way. You look here, I think that's wonderful. You can see the light reflex or the light shining right off of where it is here, and now it's kind of bouncing off. When you come over here, it's just softened it completely and it's nicely blended from there, which is great because otherwise when you're looking at her head on, you just see this.
Go back.
Yep.
Oh, wait, we got to pull the pillow up. So the other thing is, right now, because I see a little teeny bit of bruising, it's going to be a little swelling. So you can't chase that. I mean, it's really important even when you do the lips. I try not to get interrupted when I'm doing the lips.
Sure.
When I'm injecting lips, like if they need me, unless someone's like, well, there could be an instant, but I'm not in my office usually, I don't want to get interrupted.
Sure.
They come give me a message, they're going to need me, but I'm not going to stop because I'll get too much edema and then I can't make them identical twins. Okay, so then we're going to do the same thing. We're going to come and what we're going to do is come just lateral to that philtral column, and I'm going to pull it in. Little tweak. Now, I usually say a little ouch. My daughter informed me, she says a little pinch. I said, suit yourself. Whatever, just so you're going to warn the patient.
And this is a very finely threaded, superficial to mid-dermis type of injection.
Yes.
You can almost even see
much
the outline.
better.
If she were to tent up on the needle a little bit, it will literally just kind of even tent up on that dermis. So this is meant to be a very nice intradermal injection here, especially when you're trying to balance this out.
Now, when I do the philtral column, I don't mean to interrupt. Watch that. See, I tint it up and do a little retrograde. And I'm very careful with philtral columns because people have been looking at a flattened lower lip usually for a long time. So it has to be a gradual transition.
Absolutely. If you're done with that side, I don't want to, can we look at it really fast?
Oh, okay.
If
Yes,
that's okay. Let's just look at the difference between one philtral column and the other.
But see, I'm a little distracted because I have a little swelling right there.
And I won't.
See, look at that Cupid's peak. Remember, this is the Cupid's bow. This is the Cupid's peak. And so sometimes I actually come back. Volbella is probably not my favorite filler for the Philtrum because it's not really stiff enough. I'd really prefer something slightly higher G prime and a little stiffer. But since this is the syringe I was using in the perioral region, that's what I used.
I think velour and refine end up being very nice for that. But what I do love that what you did, and then I will let you finish so we don't cause too much swelling or disruption, is just like you mentioned yesterday or today, kind of leaning Tower of Pisa, you said. I think it's important to understand that on a mature face, the philtral column is actually more tangential. It is not purely vertical. So if you're going to inject the philtral column, it really does need to be something that's a bit more tangential because also the Cupid's bow is lateralized a little bit, and that's where it stems up from. So just, again, subtle nuance when you're looking at the face.
Yep, I think that's very, very important. Now, we're going to come just at the top, and then this, I always tell patients, I usually save this to last. And so then I'm going to pull just a little bit of an ouch right there.
Doing that,
and deep breath. I tell them to take a deep breath. I don't know if it helps, but it distracts. So if they focus on their breathing, of course, they told us that in Lamaze class, didn't do a damn thing. But we're going to say we did it, and so we're going to focus on our breathing. But I do think you tell people to take a deep breath, then they kind of get a little distracted from what they're thinking about. Now, what's really calling my eye is this lower lip. And I've looked at my syringe, and I see that I have a little 0.3, a little over 0.3 left, so I haven't used very much of the product at all. And I'm going to come, and I'm not going to do this with a cannula. I'm going to do it with a needle because I really want to be precise. Little ouch. Here we go now. Just like the old collagen days, because these lovely products have lidocaine in them, just so happens that we did that study back in the day when we would tell Allergan this stuff hurts too much, you need to put some lidocaine in it, and they finally listened. We did that comparison study. You need to do your second injection in an area where you've already laid down a little bit of product because it's going to hurt much less. Oh, that lip is looking way better.
Let's sit her up if we can, please. Thank you. So we can take a look here. So, really starting to see a nice change. And all of that was done with what volume of Volbella so far?
0.4.
0.4. So a little goes a long way when you're really trying to do some very fine needle kind of detailed work here. Again, we noticed that she had some asymmetry right here at her lower lip, and we've corrected that by working along the inferior portion of it in the border, the junction of the dermis to the mucosa. On her upper lip, again, she even used her white roll as her takeoff point for the philtral column, which was nice. And again, if you were working on her lip, that would have been anesthetized already, so it's lovely. And it's just starting to accentuate and just do that. But I think the biggest improvement and the best thing for her that I'm seeing is just how, again,
That step off.
That step
and we didn't
off is
see
gone
it before.
in transition.
That's a perfect example. Your hand can't fix it if your eye doesn't see it. We did not discuss that when we evaluated her back in our little room. We just didn't either one of us see it. And then we got up here with that light. It was like that step off was screaming at both of us. So really, it's the assessment and the seeing what to fix that's the very key of what we need to learn to do here today. So let's rest back, because one other little thing is coming at me, and that is this lateral commissure right here, the oral commissure. I sometimes like to be a little bit of an architect, and I put a little strut right up there for a tiny bit of support. And I only have a tiny bit left, so I'm going to make sure this side isn't as much. And see, that's quite often. Now, little tiny ouch. And I tell patients, sometimes I'm a sculptor, sometimes I'm an architect. And they say, you're really frustrated, Dr. Winkle. You've got all these things you wanted to be. And I tell them, I can't imagine being anything else in this world but what I do. It is a pure joy to go to work every day. All right, now I think I need just a touch more on this side, right further toward the white roll, just to get a little more projection, very slow. And Rick Glogow years ago published slow injection leads to less AEs, less bruising. It really makes a difference if you don't hammer down on that plunger and do that very gentle, slow technique. Okay, now we did want to talk about this mandible area over here. And we can see we do have some blunting here. Let's see, maybe we should sit up.
Let's sit up. There we go.
The problem is my hand has to get in a certain direction. I'm doing, do we use a little Renova, do we, or retinoic acid? Because we got a little fine peeling here. Maybe that's some of our topical anesthetic.
I was going to say it's probably the topical.
Okay. Now, I will tell you, if I'm going to a desert island and I can only have sunscreen plus one thing, I'm going retinoic acid. I've been using it for 30 years, and I don't care which brand you use or how you use, which one of them you use. If your skin can tolerate it, retinol, retinaldehyde, I do believe that retinoic acid on that envelope is our best winner. Okay, so we have a little blunting right here, and we had this little teeny bit. So I'm going to come in from here and run that cannula right like this. Okay, back we go. Here's my introducer. And I am sorry, there's certain limitations. I got to get my little paws in there to be able to. Can you see this way at all?
Can we rotate her? Yeah, I think, is that okay? Is that a little bit better? We can.
Okay, wait, you know what?
Turn her
Let's pull that pillow further over so I can get close. Oh, yeah. Because you got to get in a reasonable good position. So here is her gonial angle, and it's really a little obliterated. She doesn't really have, here we go, right here. So I'm going to start from right here. Now, little ouch.
And what gauge needle did you use
This
to port?
is probably the 23 gauge.
23 gauge.
Because I'm going to use the 25 gauge cannula.
And I find that also you can use a
The
25
lift,
gauge
wrestling
needle.
lift.
You don't have to use a 23 to create your port site. The difference between 23 and 25 probably isn't going to cause that much of a difference from discomfort, but whichever you feel comfortable with is totally fine.
I don't think, can you tell the difference?
Yeah, that's what I'm saying is
Yeah.
I don't really think ultimately it probably makes too much of a difference, but if we're thinking about it, you usually want to be one size bigger, but I find with a 25 gauge, if you've got a firm enough cannula that you can use a 25 gauge needle.
Which cannula do you use?
I'm big on the TSK ones.
Oh,
I like them.
And we didn't even know that.
No, we didn't.
I'm creating a little bit of a tunnel.
So in contrast a little bit to what I believe, Sheila, you may have asked earlier, here in this standpoint, what Susan's doing, of course, is working anterograde from that posterior component forward towards the midline, which is, again, completely fine. But you can also split the difference and then work retrograde, anterograde, so to speak, towards the gonial angle and then towards the midline from a single port site. Again, none of this leads to, increased scarring or problems or things like that, but it's just so important to know. Now, Susan, I love what you're doing with your left hand, which is just kind of like almost, creating a little tunnel and helping your right hand while you inject. What plane are you in?
I'm not down on the bone.
Okay.
I'm a little more, because I know I'm going over that anagonial notch.
Sure.
And even though I'm going with this cannula, I still don't want to go too deeply.
And what kind of cannula? That's 25 gauge,
This
correct?
is 25 gauge.
Okay.
And what I've done is, this is wrestle and lift. And I'm kind of a saver. I'm a little bit of a hoarder, I think. I always save like that last point too, in case I want to come and in the pre-gel even do a little depot. Or I can, if it's a lot of product that needs to be put down, come with the cannula medially from medially to lateral. Sometimes I actually start with the cannula here and go both directions from one entry point. But I find that when I really want that gonial angle accentuation, and some patients also need that preauricular fanning, and so this gives me a nice reach. And I think, again, you can put that cannula on top. You can do the push ahead in case someone needs a fanning in that preauricular region, and then you can see exactly how far you're going to be able to reach.
And often what I'll do is if I've already
Let's
sort
put
of
the
mentally
needle
budgeted for what my plan is, I think it's important to go into all these things with a plan, knowing roughly what you think you're going to be using. I'll often say that, okay, for this side of hemiface, I'm going to use 0.5 of my lift or my voluma for that posterior to the antagonial notch. And then I'll put that down, and then I'll take something that's a little bit, the lighter side, whether it's the Ultra or the Define or Velour or something like that, use that half for the rest of the angle, then I'll come back and then use the remaining lift on the contralateral side. So there's absolutely nothing wrong with using more than one product once you map it out, because for her, I certainly would be budgeting at the bare minimum 2 mLs of something that's a little bit hardier and then something that's a little bit medium in that capacity. So there's different ways of looking at it, but certainly if you're keeping with that principle that we were mentioning earlier, on a thinner face, she's got strong features, we want to make sure that we don't place too much product. Now here, I see that you're taking a vertical approach right into that, and you're almost hubbed. So that you drop that right on the bone?
Yep.
Perfect.
And you see, the nice thing is that I've been able to put some product here, saved a little bit, came and put a little product right there. And just like you said, we got to give this patient an idea. So I'm going to tell her that was Voluma 1 cc, this was Wrestle and Lift, and a little Volbella to soften and balance her lips.
Perfect. Maybe we could, once you're done with sort of setting that, let's take a peek at your jaw. Marissa, if I could have you sit up for a moment.
I got to remember to do that better, okay? You're good on that. Okay, see that? That's quite nice.
So if we look at her straight on, so first of all, in a straight on view, you can see that really you see a little bit of a difference, but that's not where we're capturing the majority of it. But you can see a nice change, but it's really once we start rotating her, and now look at her jawline, right? We've really camouflaged that little bit of that pre-gel. We've taken care, the gel, taken care of the pre-gel sulcus, and very nicely started to actually create a bit of a strut. So we look at our ascending mandibular ramus coming down to the body at the angle, and now have a much sharper accentuation without masculinizing her jaw. And let's kind of turn her this way, and you can see that we still have some work to do, obviously, here. And she's smiling, showing we can look at sort of what needs to be done and what we're going to do. But you take a look here, and then when you start to take a look here, you can just see it's kind of smoothened out and accentuated to give her a bit more definition.
Now, the other thing that I do when I'm assessing these patients, and we're chatting about what I've done here, I happen to look down to the neck, and I say, we have these little teeny stucco keratoses right here. And I'm not a real device girl. We have an IPL. I don't really like to use that kind of stuff myself. I like to do things with my hands. But while I'm here, I'd say, would you like for me to take these off? So I whip my little hyfricator around here. I touch these little things. No charge, right? No charge. I care about you. I care about your outcome. I'm not here about how much I can nickel and dime you and charge you for every time I lift my hand and put it on you. I care about that 10 days from now, you're going to look in that mirror and go, God, I love that Winkle. And so I think that taking care of other little things like that as just sort of part of, what did it cost me? Nothing. About, an extra minute. And it hurts a little bit, and I have to do talk-a-seizure, but we get through that. And it really is going to improve her neck a lot because these are very distractive, those little spots from maturity.
I think it's a really important point. We all get into this habit of thinking about a direct correlation between the cost of a capital investment like a laser and how much what did that bring in for the practice. And I think once we think about these things often as add-ons or things that are just really nice to be able to just do for patients who are already kind of paying into the system, and it differentiates our practice from many others. If we've already have, for example, BBL or a Cyton laser with a skin-tight component, if I'm doing an abdominoplasty on someone, or I do liposuction, I do a mini brachioplasty, there's no disposable. It costs me nothing in terms of other than the time for one of my staff members, which is valuable, but I can have them doing this and they're like, oh, we're just going to do this for you. But in the real way, they've actually kind of already paid into the system because of the price of our surgical procedure and things like that encompasses some of these treatments. So I think it's really important to understand if you differentiate yourself, you don't always have to see a direct correlation that I paid X amount for this laser and we treated this many people with that laser and therefore X equals Y and equals Z, and that's what we have to make sure. It's about the experience that you provide and something different that you do and not nickeling and diming over a very basic treatment that doesn't have a disposable that costs you nothing. So that is, I think, a very important thing. And right now, Susan's working on her contralateral temple. She's right down onto the fossa. She's injecting at her safe point. Nice, slow, uniform injection and filling out that temporal hollow in through there.
And my patient, who happens to be a dermatologist.
I'm a PA.
Oh, PA, okay. You work in dermatology. Okay, a PA in dermatology. And so she says, it's really easy. But look how nice and steady. It's very important for patients to have a sense of security that, number one, you know what you're doing. And number two, that you're not in a rush, that we're doing it very gently. I'm not thinking about the fact Jean Ann is aggravated because I am 45 minutes behind, and I should be getting out of this room right now. And she comes and looks at me, Dr. Winkle, what are you doing in there? So that wasn't so bad, right?
Nope.
All right, so that was an easy thing. Now we're going to come with our cannula down here. Oh,
and while she's starting to work on that jawline, maybe we could just cue that one. Since we're saying the same thing, let's cue that video, and I can talk through a more superficial temple injection with a cannula. This was the one that was squished together a little bit earlier, but we've kind of made sure that the formatting is different. And I know it says courtesy of Susan. It's actually my case. I think that was left over from the previous slide, which is totally fine. So here I've kept it in real time so you can watch what it takes, about 2 minutes or so. And I wanted you to see me even struggle a little bit with first trying to get through because of the flexibility. I did this one with a 27 gauge cannula, and since then now adopt using a 25. I felt the 27 may have been just a little too wimpy for me to kind of break through the dermis. But again, once we just started and I start getting my tunnel set up, it becomes a very nice, easy, straightforward injection. And through one lateral port site, so I use a 25 gauge needle for a little pinch, 27 gauge cannula here. Since then, I can't remember the last time I used 27. I only used 25. But I thought it was important for you to see me struggle a little bit with a 27 and without it fast forwarded or anything, just in real time. Again, that took, 15 seconds to kind of just tunnel through with the 27, and that was when I was still using that. And now I orient my hand, and I just start a little bit of a thread, and you can see I start with this just very fine little droplet technique. You'll see how much my hand oscillates back and forth, and if you look, I've only at that point placed maybe 0.1 or 0.2. In this superficial plane, you don't have to worry about a lot of things from an anatomic consideration because all the concerning anatomy, the vessels are all deeper here. So if you're not necessarily interested in wanting to drop this deep onto the bone or you feel like there's a lot of hollow to fill out, you can achieve a lot of very nice correction by staying in a more superficial plane. And again, I've stayed in the same port site. Once you get it started, it just flows nicely. You'll see these little bumps right now. If you pick the appropriate material, you can very quickly and easily, I put a little bacitracin ointment or a little HA5, lay it on there, and just use that to massage it out, and the patients are good to go. You don't have to worry about piercing through the fascia of any muscle. You don't have to worry about a little bit of that TMJ pain. So this is something that can be done. The other thing I'll do often from this angle is, if I need to, is I'll change vectors and go right below the eyebrow and create a little bit of a strut on a ptotic brow just to give it a little bit of a bolster. So all of that can be done from one basic port site out here on the side. And I get all the way to my temporal fusion line as well and fill out. If you notice, my little beads go all the way, those little droplets are going all the way up to her hairline, because I want to make sure that she doesn't end up, and it blends nicely into the hairline so she doesn't have an obvious step off. We don't want to just camouflage that deformity. So here we are. We place that in. Pardon me? I think here I was using some Versa because I wanted to see how malleable it was to get through a 27 gauge. So I just start massaging that through. And then I think if you could just advance to that next slide, if you don't mind, please. And this was a patient immediately after. And I'll have to look to see if I have her 3/4 view. We showed this slide earlier when we were kind of moving through things quickly. But again, immediately after, this was velour. No increased amount of swelling, no bruising that she had, no sort of little HA worms or little sausage or anything like that. Everything smoothed out very nicely, and she walks right out of the office with correction. And we can look again, let's advance it one just to look at the red line contour, and advance it over so we can again just sort of follow that progress. And you can see that those few millimeters of creating a less concave surface really makes a nice change. You can look at the contralateral left side, which doesn't have the red mark in front of it, and just look at the natural progression. That was after 1 cc into her temple, and then after we corrected both sides and added just 0.3 more, really took it home and just smoothed it out nicely. So that technique was, again, it was a 25 gauge cannula with velour on this patient. I just showed you a 27 gauge with some Versa that was already mixed in with about 0.1 of 2% lidocaine with epinephrine.
So we're really, bottom line, about trust with the patient, about caring, and about that team. So I think we did all right. You're good.
Perfect.
So what did we do before? We
You wanna
can
sit up?
applause. Let's applause for her. That's okay. Sorry, I don't mean to interrupt that. While we were looking at the temple filler on the cannula, what did we do along her left jawline now? Same thing? Can
Same
you
thing,
talk
yeah.
us
We
through? So
put
did.
same thing, cannula work posteriorly, a little bit of depot injection. The lip is looking much more balanced, a syringe of volume in the temple. So I think, and the nice thing is I find that this is durable.
Can we capture just a little bit? If we could zoom out. There we go. Perfect. Pan out. Perfect.
Like this lasts a long time.
Mm-hmm.
I think it's because there's not as much blood supply down in there, because you're underneath, you're supraperiosteal under the muscle, and there's not a movement. So those two variables, the product seems to be, I find patients a year and a half, 2 years out, finally come back and say, remember what we did? Ma, you think I need some more of that? So you can come back in a couple years.
I will.
Let's take a look at her left jawline now, if you don't mind. We can look through here. Can you just turn maybe a bit more, if that's okay, so we can just try to capture through there. So good. So when we're looking here, we still have just an element of bump, but that could just as well be a little bit of swelling as we've worked.
Yeah, from entry
here.
point.
Exactly, just from the entry point. And then again, we've really started to create a nice amount of contour here along that posterior portion of her mandible, and start to really accentuate a bit of her jawline to give her that nice jaw and neckline. And then when we look at her anteriorly, and you can go and put your feet back up for us, Marissa. Thank you. When we look at her straight on, we can really see nice change, and it complements. You don't see nearly the same step off that we thought we saw earlier with these full cheeks. You think that someone with a full face, you're adding volume in, it's going to make it look fuller. But it's all about strategically where that volume is being placed. We didn't want to put anything in her mid-face. She didn't need it there, but we very nicely have deposited some of our voluma in through this area, and all of a sudden now you just have just the right amount of concavity, and she's swollen right now. That'll settle a bit, and then she's going to have it settle in just so lovely. So I think, again, it's really nice because it's just the right amount of correction and not over-corrected, which we certainly wouldn't want to do.
And she doesn't really have many veins superficially, so she doesn't have that. But don't forget, if you do see that prominence of the superficial veins after that deep injection, it's only temporary and they go away. Do not overcorrect this. I think it's still a good OG angle that we have.
And so you can see we started right here in the middle and then worked our way, got the cannula all the way back and tucked it in across. You can see we got it all the way to the angle of mandible, stayed in that same site, and then worked anterograde as well, massage it in, and then just a little bit with the needle to get that central chin component because he's got more surface area. So really sped through it, but again, you can see the difference. Dr. Winkle had a very nice technique starting posteriorly, advancing, wonderful. Here we're just sort of splitting the difference. One injection or one port site going that way, same port site, and just flipping our cannula, advancing centrally and capturing what we needed. And then we just wanted to do a little bit into the central chin as well in that menton. That was one cc of Voluma, and then I used some Ultra Plus on about 0.2 to 0.4 on the central chin. Yeah. Correct. Yep. Just because we wanted to give him a little bit more masculinize the jawline a little bit. This gentleman is he's a plastic surgery resident who was interning with us, spent time. He was a massive weight loss patient, and so he'd had skin laxity, so we're filling his soft tissue skin envelope out, but he lost the weight through diet and exercise, not through bariatric surgery. So he's a young guy, but still lost a lot of volume. So I said I'd do some jawline work for him. He was very pleased. I'll see if I can dig up his photos for the before and after, but I just think it was an important thing to see that we've created, because he's thin now, but he was losing and kind of having that mature skin and soft tissue envelope. We don't want to lose volume there, so we wanted to actually bulk it up and give him a bit more of that masculine feature and sturdiness. Exactly. That's right. And you can see when he sits up right now, you can see that he's got that kind of going on. It's a little bit softer when he's laying down.
This was 1 syringe of Restylane Lift, 1 syringe of Lift, a Voluma, and a Volbella.
Wonderful.
5 syringes. She's going to have one little bruise right here. But outside of that, telltale.
Yes.
Okay, so my question is, what is your tips to avoid giving somebody a duck lip? Because randomly, I'll get a patient where the filler sat different in their lips than I'm not overfilling, you're not using a lot of product, but sometimes they'll come back and I'm like, that looks a little ducky. And I hate that look more than anything, but some people's lips just don't, they just hold filler a little different.
But I think it's just like what we did here. You have to treat that ergotrid. You have to treat the platform of the lip as well. You can't just always address the lip proper, the wet dry line and the white roll, because it's going to want to evert that sometimes. And so that's why you have to preemptively think about and treat the ergotrid.
So I think that is a very important consideration. Fundamentally, I'll tell you kind of from a philosophical standpoint, we sometimes get into the habit, if we only have a hammer, the whole world is a nail. And what does that mean? There are patients who just aren't going to be a great candidate at times for lip filler unless they're willing to undergo a lip lift, for example. And I'm not saying that I'm a big fan of doing that operation. It can heal well, you can have no issues, but ultimately what we have to remember is some patients don't have favorable anatomy. And so if you're not looking at them and accessing, sort of looking at their lip in particular, and they come in and they have very little vermilion show, and they're all atrophic, and they've lost their tubercles, and they've lost fat, and they basically are showing in pencil thin with just a sliver of some vermilion that's pink. I think it's very challenging to get that patient a good outcome without them ending up with a little bit of duct, because if you try to evert their lip and inject along what's left of a wet-dry junction, it actually just will tuck it back in even further, and you can't really get it to lift up. And you're kind of smiling and nodding your head, I can see.
That's
so
exactly
I think,
what it is.
and that's what happens, right? So
those
ultimately, we just get into a habit of thinking that everything should be able to be solved with this syringe. And you know what? Unfortunately, like I said, for many patients, not unfortunately, people think you may actually have to do surgery. You may actually need a procedure. Heaven forbid we say that word anymore. But yes, the right answer may be not filler fatigue or fillerexia. It's doing an appropriate surgical procedure and then building out that lip. They still may need filler, but they need something else to shorten the distance, because that ergotrid is elongated throughout the maturity and throughout that, dare I say it, aging process.
But
right?
I've had patients I actually thought I should refund their money because they had just what you said, those pencil lips. And I put that stuff in, and instead of coming up, that sucker just rolled in. And I looked at him and I said, I don't think they look one bit better than when I put it in. And on occasion, and that's really those pencil thin lips that I don't know that we can fix with that filler.
Or without surgery.
Without surgery.
Correct.
That they have to have
Yeah.
surgery to elevate and pull it up,
Exactly,
because it's
right.
just not going to work.
And you
Yeah.
will need to do it. It's a two-part process. When I do those cases, I tell the patients that this is not going to take care of the problem. It's like lower eyelid surgery as well. There's all sorts of discussions about blepharoplasty and lower lid fat repositioning into the tear trough and do this and do this. I tell patients all the time, if you're only thinking that this process is going to be solved with a surgical intervention, you're wrong. It may look great for the first 6 months to a year, but we're going to need to place some volume in. We've removed volume where you didn't need it, but some volume needs to go back into this area to keep it looking fresh. And I tell patients, if you plan on doing a facelift and a neck lift with me and not do anything for the next 10 years, again, you're in the wrong practice. There is maintenance. There are things that need to be done to maintain this outcome that we've done, whether it's a peel, whether it's lasering, whether it's an intermittent sculpture treatment, whether it's replaced with a little HA. The aging and maturing process is going to continue. So I think, you started to kind of nod your head. It seems like we hit the same head, in terms of thinking about that patient. And bigger picture is, if you only have a hammer, the whole world is a nail. You've got to be thinking outside of that and be like, okay, there are other procedures, and though this patient may not want it, to get them the right outcome, you may actually have to undergo something other than what I can do for you in this office right at this moment.
In treating the décolleté area, you talked about
Yes.
Sculptra. So I wanted to know, how do you reconstitute in order to treat that area? And if you had any problem with any
Good
kind
question.
of nodule?
So how do you reconstitute? You can't put 20 cc's in the bottle, right? About the most you can get in that bottle is 10 cc's. So my assistant mixes up the Sculptra with 10 cc's. And then she draws up 1 cc in a 3 cc syringe and another cc of usually the bacteriostatic water, so that you have essentially a 20 cc reconstitution, but you have to do it outside the vial. And then she draws up all those little 3 cc syringes with 2 cc's in each one. Just makes it easier to follow. And so we do that for the décolleté. I do that for the arms. It works nicely. It's not overnight. It takes usually 3-4 treatments. So it has to be someone with a reasonable budget to be able to do that. It works for the knees, above the knees. And I haven't had any problems, any complications. But you can't depend on Sculptra alone. It really has to be that package team approach here. You have to put the Sculptra down and then efface the fine lines with a low G' product like Belotero, blended Belotero, and do that. And then sometimes they come back maybe 6 weeks later when it's all settled in and put even a little more superficial filler. Then you also have to address the outer envelope. Sometimes they need a little liquid nitrogen. Sometimes they need very gently, so not to depigment them. And the brown spots, you need to help the brown spots, the fine lines, the volume. People even talk about using some neuromodulator in that décolleté. I don't know. I'm not sure what I'm relaxing, or it doesn't make much sense, but I've sort of tried it. But I can tell you that, again, patients don't come in asking you to treat their décolleté because nobody's talking about it. Nobody's out there. It's not in the magazine so much. It's not on television. It's not on the doctors, whatever. And so I think that patients love it when I address their décolleté. And that's generally after I've spent most of the money I can spend on their face. And then I'm looking down, I go, oh, we can treat your hands, or I can treat this, or I can put some filler where you're a little saggy, or crepey, here. And these are other off-body areas that I think we can find very helpful.
Sorry, when you do a liquid rhino, what are your tips for safety?
Okay, safety. I think that's really, really important. And your description of the anatomy and everything was just beautiful, Sasheen. I find, first of all, I inject mainly midline, okay? And if you look at the vessels, you need to look at the branches of the angular artery, and I always compress with my non-dominant hand laterally, and I use very, very low pressure. Because think about it. Even if you get in a vessel you got to be pushing pretty hard to get that stuff to go in here, in there, down, and around, right? So very low plunger pressure in a back-filled TB syringe in order to have controlled, tiny little aliquots. So it's side pressure, midline, tiny aliquots, low volume. You'd rather have them come back in 6 weeks. Now, the most important question here is, will I save the syringe? No, I won't. I'm sorry. I can't save your syringe. We'll find somewhere else to put it. Somebody needs it in their ear lobules. There's always somewhere to put it. But they say, well, if I use half a syringe today, can I come back in, 3 or 4 weeks and let's use the other half a syringe? What am I going to have in my refrigerator? Little labeled syringes all over the place? No company will back you up if you save the syringe. Did that help
From
that?
an anatomic standpoint, I think one thing that I would echo is I think we talked about vascularity a lot. We're thinking about tissue depth and where do you want to place this. And remember, the lion's share of the nose is cartilage, right? If you think about looking at a skeleton, when you look at the nose, you have the coena and everything else. I mean, the only thing you're really seeing are nasal bones, which can often be very short. And that often isn't always the place where you're trying to camouflage if you're looking at profile view and a dorsal hump. So you really need to make sure that you're, again, injecting and moving very slowly, because when you're looking for something on which to land and you're distal to the nasal bones, you could easily pierce right through their cartilage and inject it in, intracartilaginous or through the upper lateral cartilages. So I think that it's really important to understand that when you're parking this product, using smaller gauge needles, so you've got some tactile backing if you're not, banging through it and just pushing down. And you also need to understand that, remember, the cartilage is pretty superficial at this stage, but you don't want to be seeing intradermal blebs of this either, because that can also compromise this skin and soft tissue envelope. So you really need to make sure you're kind of pinching. I like the idea of pinching off the blood vessel, but I also pinch and really present the tissue away from me and then go down and feel exactly for my nasal bones. If I'm a bit more proximal or higher on the nose, if I'm a bit more distal, you can feel their lower lateral cartilages as you get more distal to the tip, upper lateral cartilages, which are paired on both sides. You have that dorsum, and that's placing it right onto the septum itself. So you just want to be feeling for something firm on which you can inject, and that also will typically keep you a bit safer because we know the blood vessels aren't in that plane. When I'm degloving a nose from a rhinoplasty, I'm staying right on top of those cartilages, and there's a very nice fibrous and loose plane, if anything, between the skin and the cartilaginous components. So that's where you want to be. So depth, feel for something below you. Don't just get into the skin and think you're correcting intradermal. This is not meant to be injected there.
I also think the tip of the nose is a really important area to not over-inject, because you do not want extravascular compression, because the tip of the nose, you can just feel it. There's nowhere for stuff to go, right? It's so tight, that skin and tissue. Here you've got some laxity, you've got some place for that filler to go, but very importantly, gingerly, very, very low volumes, even if you have to do it as a staged procedure.
And to comment on our colleague that asked about Sculptra, we're going to be talking about all things Sculptra for body work tomorrow. But one of the things also from an injection technique perspective, once you've got it nicely expanded or, I guess, reconstituted, and the way Susan likes with maybe like 20 mLs, or I sometimes will go 15 mLs for texture, is this is going to be an intradermal injection. You got to be threading it through that dermis, cross-hatch it in comparison. I like injecting décolletés as well, but we use it a lot for a lot of skin texture, quality types of issues. And tomorrow,
but I use a cannula here. I use a cannula.
Sure.
A big, long cannula, a 2-inch cannula to go over that. Fewer percutaneous sticks, less bruising with that.